by the imaging of the normal liver, and as you all know, starting to image the liver, we should know what are the indications for imaging, how can we prepare the patient, how can we examine, then how can we interpret the images. These are, in my opinion, some of the most relevant clinical indications for which we examine the liver, either by ultrasound or by CT. And I think one of the most important indications is to assess an equivocal imaging find. Many of you may have a patient that has been examined by ultrasound or have a barium study, for example, and a lesion was discovered, and we would like to verify this lesion. Then one of the ways is to obtain a CT scan. Then assessment of the hepatic neoplasms, as well as in the imaging of the liver, is one of the items in the metastatic workup of primary malignancies elsewhere in the body. The biliary problems are also assessed by CT scan, better than ultrasound. Also, the diagnosis of hepatic vascular disease, anything concerning the portal circulation, assessment of traumatic insults for the liver and the related organs, and as you all know, one of the major indications nowadays is to assess the liver in cases of liver transplant, either in the donor and the recipient. Then to examine the liver by CT, we can prepare the patient using what's known as the oral contrast material. It is known as the gastrographene, and this gastrographene should be diluted. It's taken orally just to opacify the intestinal loops. Then this gastrographene is not indicated in acute abdominal trauma and in cases of renal colic, as well as in dehydrated patients. This is one of the values of gastrographene. It can discriminate between the normal bowel loops and the diseased bowel loops, which are not filled by the contrast material. Also, it can identify if this mass is of bowel origin or not. If you see a bowel loop that is filled by gastrographene running inside the mass, then you know that this mass is of bowel origin, and you start to differentiate between the small bowel lesions and the large bowel lesions. Okay, how to prepare the patient for the CT? Just by fasting for about 4 to 6 hours. Then we obtain what's known as the scanogram. And the scanogram is just an initial image for the abdomen, just to locate the site or the area to be examined. And we identify for the CT scan the range of examination, which should start from the diaphragmatic cupula and end at the iliac crest. This is the range for scanning of the liver. Then we scan the liver every 10 millimeter or 1 centimeter scan interval, and this is one of the images in the liver. You can see the liver parenchyma on the right, and this is the spleen. This is the stomach, which is filled by the orally administered contrast material. Then you know that this is the aorta and this is the inferior vena cava. Before we inject the patient with contrast material, we should have what's known as the pre-contrast scans. And we scan the patient before injection of contrast, then we repeat the scan after injection of contrast. How you know that this patient is injected or not? Just look to the aorta. If the aorta is not containing contrast material, this is the pre-contrast scan. Then in the post-contrast scan, you can see that the aorta is stained with the intravenously injected contrast material. Also, you can see the contrast material running in the vessels inside the liver. What is the value of the pre-contrast scans? In some cases, there are focal lesions in the liver, as I am pointing now, multiple focal lesions in the liver. If you do not have this examination and you inject the contrast material directly, then the lesions will take the contrast material as much as the normal liver parenchyma. Then you will feel that the examination is absolutely normal and you cannot discover these focal lesions. Then we, as a routine, we usually examine the liver before injection of contrast material and after injection of contrast material, just to look for the lesions that may take the contrast material as much as the normal liver parenchyma. Then this is a pre-contrast scan, and look to the aorta, and this is a post-contrast scan. The aorta is stained with contrast material. The liver is markedly enlarged, and you may imagine that there may be some of the focal lesions scattered throughout the liver. But in this examination, which is also a post-contrast study, look to the aorta, and you can identify so many hepatic focal lesions. And this examination is known as the triphasic study, where you inject the contrast material intravenously, then you scan the liver while the contrast material is in the arteries. How can you know? By the appearance of the aorta, which is very bright, because the contrast material is very dense in the aorta at that time. Then you scan the liver when the contrast material is in the venous side or in the portal vein or in the inferior vena cava, which is known as the venous phase. Then you scan the liver at a later stage, which is the third stage, hence the name triphasic study. The triphasic study, you scan the liver in the arterial phase, in the venous phase, and in a later phase. What is the value of this study? As you all know, that most of the hepatic focal lesions are supplied by the hepatic artery, while the normal liver parenchyma is supplied by the portal vein. Then you do not have the chance to see the hepatic focal lesions well unless you scan the liver while the contrast material is in the arteries. Then you have the chance to see the focal lesions well enhanced. Look for this scan, and the patient is injected with contrast material, but you can hardly see a focal lesion in this area. And after injection of the contrast and they scan the patient in the arterial phase, look to the density of the aorta, then you can easily see the focal hepatic lesion. Nowadays, the triphasic study is mandatory for accurate evaluation of the hepatic pathology. Then you see this is a pre-contrast study, and this is the arterial phase. Look to the aorta, then you can see the enhancing focal hepatic lesion inside the liver. Then later on in the venous phase, you can see the lesion as well, and in the delayed phase, after washout of the contrast material, you can still see the lesion as well. Then just few words about the normal anatomy of the liver. The liver is present in the right hypochondrium, and you can see this is the normal liver. This is the spleen, and this is the stomach containing the orally administered contrast material. And you can see here the aorta and the inferior vena cava as well. If you go down, this is the normal liver, the spleen, the stomach, and the aorta. And you start to see here the pancreas, part of the pancreatic body and tail. And this is the stomach, this is the liver, this is the aorta, and this is the inferior vena cava. And here you can see in this area the porta hepatis, where you can see the portal vein. And you know that the liver tissue, which is located between the portal vein and the inferior vena cava, is known as the caudate lobe. Then if you go down, you can see the gallbladder, and you see the liver as well. And you start to see the kidneys, the spleen has finished, and you see some of the bowel loops inside the abdomen. Going more down, you can still see part of the liver, you see the gallbladder, you see both kidneys, and you can see the left renal vein crossing the midline to join the inferior vena cava in front of the aorta. Then further down, you can see the region of the pancreatic head, the distal part of the liver, both kidneys, the aorta, and the IVC. More down, and you got the terminal part of the liver, the most inferior part of the liver, some of the bowel loops, aorta, IVC, left kidney, and the right kidney. Then the liver has been finished, and you see also bowel loops only inside the abdomen. This is the right kidney, this is the aorta, and this is the inferior vena cava. Then we came close to the liver to see more details. And you know that the liver has two lobes, the left lobe and the right lobe. The discrimination between both lobes is done by a line drawn between the inferior vena cava and the gallbladder. This is the left lobe, and this is the right lobe. The left lobe is divided into two segments by the fissure for ligamentum teres, the lateral segment which is away from the liver, and the medial segment which is near to the rest of the liver. The right lobe is divided into an anterior segment and posterior segment by an imaginary line drawn horizontally from the level of the inferior vena cava. and this is the left lobe, 2 segments, and this is the right lobe, 2 segments. Then you will know that the liver is now surgically divided into 8 segments, and the segmental anatomy, or the surgical segmental anatomy, can also be seen in the CT scan. And you see that this is the left lobe, which is the lateral segment and the medial segment, and this is the right lobe, the anterior segment and the posterior segment. Each segment is further subdivided into 2 subsegments, and these are the numbers for each segment. And you see the lateral segment 2 and 3, the medial segment 4A and 4B, the anterior segment 8 and 5, and the posterior segment 7 and 6. How can you, in a simple way, know these segments? Just look to the CT scan of the abdomen, and you have to identify whether you are in the superior segments or in the inferior segments. What is the anatomic landmark? The anatomic landmark for the inferior segments is the splenic vein, which is running posterior to the pancreatic tail. And you may have the pancreatic tail as a reference. If you see the pancreatic tail or the splenic vein, then you know that you are cutting in the inferior segments. Then this is the plane of cut, and this will be segment 3, and this is 4, this is 5, and this abscess will be in segment number 6. Then in the inferior segments, the segments are as I have said, 3, 4, 5, and 6. Then how you know that you are in the upper upper segments? Look to the inferior vena cava. When the inferior vena cava is adherent to the liver, I mean lying in the fossa of the inferior vena cava and the visceral surface of the liver, then you are cutting in the superior segments. In the superior segments, you have segment 2, segment 4, segment 8, and segment 7. This is 2, this is 4, this is 8, and this is segment 7. Then, to know the surgical segmental anatomy, look to the level. If you are in the inferior level, then the segments are 3, 4, 5, 6. In the superior segment, 2, 4, 8, and 7. Then look at here. Which level is this one? It is the superior one. Why? Because the inferior vena cava is adherent to the liver. Then the superior one is the segments above 2, 4, 8, and 7. Then this is the inferior segment where you can see part of the region of the pancreas. Then you have segment 3, segment 4, segment 5, and segment number 6. Then if you look to the liver, you cannot see any focal lesion inside the liver. This is normally. But if you see a focal lesion like this or a focal lesion like this, you have to discriminate between cystic and the solid focal lesions, because most of the cystic lesions are benign and most of the solid lesions are malignant. And this is the appearance of a cystic lesion, and this is the appearance of 3 solid focal hepatic lesions. Then you see these lesions, they are cystic, and you are dealing most likely with a benign case. And you see these lesions, they are solid, and you are dealing most likely with a malignant case. And we'll discuss this in the second part of this talk. Then look to the liver. The liver, its density is almost exactly to the similar to the density of the spleen. But here you can see that the liver is slightly hypodense or less dense compared to the spleen, and this denotes that the liver is infiltrated by fat. And this fat may be mild and may be severe, like this one. And you see here the liver parenchyma is almost black, secondary to the deposition of a large amount of fat inside the liver compared to the density of the spleen. The normal liver is almost similar to the density of the spleen. But if you look to this case and you see the liver is similar to the density of the spleen, but the liver is shrunken, the contour is irregular, then you know that you are dealing with a cirrhotic liver. But in this case, and you look to the aorta, there is no contrast. And the liver in this case is more dense than the spleen. Then you know that there are some material that has been added to the liver parenchyma, and this is what we call the storage diseases, hemochromatosis, glyconestosis, and so on. Then to diagnose fatty infiltration, you should have a contrast study, and in this you see the liver is hypodense compared to the spleen. But to diagnose storage diseases, you should have a non-contrast study, and the liver is more denser than the spleen. Then normally you don't see any bile ducts within the liver. The normal bile ducts are not usually seen in the liver, but whenever the bile ducts are dilated, you will see multiple linear hypodensities or black lines running through the liver. And these black lines represents the dilated bile ducts containing bile, and bile is almost similar to water, and water appears black in the CT images. Then you can easily diagnose that this case has a biliary obstruction, and the bile ducts are dilated, as you can see throughout the liver parenchyma. Then, if you see multiple linear dense shadows within the liver, you know that these are the vessels. Vessels in the liver may represent the hepatic artery, the hepatic veins, and the portal vein. Then, you know that to see the hepatic artery, you should have the arterial phase and look to the aorta. When the aorta is very dense, any branch running through the liver parenchyma will be a branch of the hepatic artery. Then to see the hepatic veins, they are only seen in this section. When the inferior vena cava is adherent to the liver, you will see three major branches entering the inferior vena cava, and these are the hepatic veins. This is the superior one, the middle one, and the inferior one. Any other branch running throughout the liver parenchyma is just a portal venous radical. Then the hepatic artery will be seen in the arterial phase. The hepatic veins are only seen in this image, while the inferior vena cava is adherent to the surface of the liver, and any more branches are considered portal venous radicals. And this is an examination which can be done recently by CT scan. It is known as CT portography. You just inject the contrast material intravenous and order the CT to obtain images for the portal circulation. Then you can see this is the spleen, this is the splenic vein, and this is the superior mesenteric vein, this is the portal vein, and these are the portal venous radicals. Before this era, you used to introduce a needle in the spleen and inject a big amount of contrast material, and to see the portal circulation, there are a risk of splenic rupture or subcapsular injection of contrast material and so many complications. But now you inject a little amount of contrast material intravenous and use the CT technology to have this image. And in cases of portal hypertension with liver cirrhosis and splenomegaly, you can see this is the splenic vein, this is the superior mesenteric vein, and this is the portal vein, and you can see the esophageal varices, which are dilated tortuous vessels near the gastroesophageal junction. Also, you can see a portal vein thrombosis very easily, more sensitive than the Doppler studies, and using little amount of contrast material injected inside or through the venous route. Then this was a quick review of the anatomy of the liver, and you expect to see what do you expect to see through the CT scans of the liver in normal conditions. Then these are, as you know, I used to project some of the quiz cases at the end of each talk just to test your knowledge. And you know that number 1 is the liver, and number 2 is the stomach, and number 3 is the spleen, and the arrow points to the diaphragmatic cross, which surrounds the aorta, and this arrow points to the aorta itself. Then, what is that? This is the tail of the pancreas, and this, yes, this is the gallbladder, and yes, this is the left kidney, and what is that? Inferior vena cava, and this, caudate lobe, very good, and this, no, the hepatic veins will be seen when the inferior vena cava is adherent to the liver, and the hepatic vein will enter the inferior vena cava. But this is the region of the porta hepatis, and you know this is the portal vein, and this is the inferior vena cava. The tissue between the portal vein and the inferior vena cava is the caudate lobe. Okay. Then this is the pancreas, and the vessel running posterior to the pancreas is the splenic vein. And this is the landmark that you are cutting in the inferior segments, okay? Then what is that? This is the left kidney. And which segment is this one? The number of the segment? 3. Yes, this is segment 3, okay? And this? 6. Very good. And this? This is the caudate lobe number 1. Okay. Then what's your diagnosis? A storage disease? Or, you know that in a storage disease, the liver is more dense than the spleen. Okay? But here the liver is more black than the spleen. Sorry? Yes, this is fatty liver, and you see this is the liver which is black than the spleen. Then you know that the liver is infiltrated by fat. Okay, and this is fatty liver. Then what's your opinion? Okay. Yes. Dilated biliradicals. Okay. You see the liver is just like the spleen in the density, and you see multiple linear hypodensities running throughout the liver parenchyma. Then you know that these hypodensities represent bile ducts, and the normal bile ducts are not usually seen by CT, but the dilated biliradicals will be seen like this. Then you know that the patient had biliary obstruction. Then this is the aorta, and this is the inferior vena cava. This one is the inferior vena cava. And what do you think about this vessel? Which one? Yes, this is the inferior hepatic vein. Then you know the inferior vena cava, which is adherent to the liver in this section, is the landmark for the superior segments. Then which segment is this one? The number of the segment? 2. Okay. 4. 8. 7. Very good. Okay. What do you think about this liver in a female patient, 48 years old? Sorry? Yes, this is a storage disease. Very good. This is the stomach and this is the spleen. There is no contrast material in the aorta, and the liver is more dense than the spleen. Then you know that this is a storage disease. One of the storage diseases is the hemochromatosis. And this is the end of the first part of this talk. Thank you very much.